So good afternoon, everyone, and thank you for joining the December session of the Ohio Workforce Coalition's webinar series. I'm excited to bring our speaker to you today, and I'm also glad to see that we have a lot of new participants on today's call from a wider group of stakeholders, and that is really important to this particular topic. To accommodate our guests, we have switched up the flow a bit, and you will actually have two opportunities for Q&A. Please go ahead and enter any questions you may have into the chat as we're going so that we can capture those and share them when it's time. And you can also feel free to use the chat to introduce yourselves to other attendees, respond to questions, or share general comments. The coalition webinars are on the usually the fourth Thursday of every month at 1 o'clock. They are recorded and available on the coalition website. So today's session will be available, and you can find at least the last year of webinars available at ohioworkforcecoalition.org. There are other links and resources at the website. If you have an idea for a webinar or a resource that you'd like shared, please just send me an email, let me know, and we can consider that topic or those resources. Finally, please consider following us on social media. You can find us on Twitter at OhioWFC. And that's the first place really we put all our updates and share about what's happening in Ohio, add resources, make announcements, and so on. So for those of you who've been here for a while, you've heard me say this before, but the Ohio Workforce Coalition has been around since 2007. We bring together leaders from education and training institutions, economic and workforce development, business and industry, labor, and human service providers, all to talk about the workforce needs across Ohio. We promote public policies that build the skills of adult workers, meet employer skill needs in quality jobs, and strengthen the workforce system to ensure opportunity and prosperity for Ohioans. Today, we are joined by Angelina Del Rio Drake, who will be talking about the state of the direct care workforce. From demand for workers to the quality of those jobs, there really is a lot to talk about. And we are starting this conversation with a national perspective, and we'll round it out with an example of how one local area in Ohio is working with employers to address the needs of the direct care workforce in their community. Angelina is the Chief Strategy Officer with PHI, where she leads the alignment and implementation of strategic plans across the organization. Under her leadership, the strategy team supports staff collaboration and learning, system development to strengthen, measure, and promote PHI's impact on direct workers and clients and employers. And I actually met Angelina back in 2018 when we both had the privilege to be part of the Aspen Institute's Job Quality Fellowship. So drawing from her own experience as a home care worker and years of advocacy work, Angelina has designed and launched numerous programs and projects to improve job quality in direct care. She's a resource for technical assistance, to long-term care training, care integration demonstrations. She's conducted care integration demonstrations across the country and been a featured speaker with the National Academy of Sciences and Engineering and Medicine and the International Health Workforce Collaborative. She's got a range of publications that I will put in the chat, and I am super excited to be able to have you hear from her today, and I know that you will find value in what she has to share. So with that, I'm going to turn it over to Angelina.
Thank you so much, Rebecca. I'm thrilled to be with you all today. I'm going to go ahead and get my slide up here on the screen for everyone. Excellent. So this afternoon, I'll be talking to you about the direct care workforce and the job quality implications for Ohio. As Rebecca mentioned, I'm here today representing PHI. It's an organization I've been working at for the last 10 years. We are a national nonprofit committed to improving direct care jobs. And we do this through two main lines of service. The first is our research on this workforce, our policy advocacy and analysis, and the public education that we do to help change the regulations, the laws, and the broader environment in which long-term care takes place. But this work is also informed by our second service line, which is the work that we do on the ground. We work side by side, direct care workers, their support staff, employers in long-term care settings, and with consumers and family caregivers to understand the challenges involved in direct care, to improve training, job design, and other employment practices. Because we believe that a quality direct care job is key to producing quality care for older adults and people with disabilities. PHI was founded in 1991, so this year we are celebrating our 30th anniversary. We believe we bring a unique and informed perspective that includes both the regulatory and policy perspective and the on-the-ground experience in long-term care. Now, before we get into some of our workforce content, I just want to do some definitions. Long-term care is a complex space. I know we have a mix of both people deeply embedded in this field and familiar with these terms, and folks from the larger workforce community on the call. So I want to get specific about who PHI is talking about when we talk about direct care workers. So our definition is that this is the workforce that assists older adults and people with disabilities with essential daily tasks and activities across a range of long-term care settings. So just important to note, it's not the workforce that provides exclusive care to children with conditions that require care in these settings, and it's different from folks who may be in frontline healthcare roles like nursing that are critical to this space, but we're specifically focused on the direct care workforce. And we break that workforce into three main categories when we look at this across the US. The largest category are home care workers. So this is over 2 million personal care aides and home health aides, though titles certainly change across different regions, settings, and payment programs. And these are individuals who support care in private homes. Secondly, our nursing assistants who work in nursing homes. Nationally, that's over 500,000 workers who provide services to residents of 24-hour nursing care settings. And then lastly, we think about residential care aides as more specific to where care takes place. Residential care aides may be certified with a home care or certified nursing assistant title, but they deliver either personal care or other services to individuals who live in group homes, assisted living communities, and other residential care settings. And when we're looking at Ohio's workforce, the home care workforce includes two main titles. Again, these can vary across different settings, but the home health aide title is a certified title that refers to workers who are typically agency employed aides who assist consumers with both health-related maintenance and monitoring and personal care. This workforce it requires a federal minimum training standard of 75 hours. Some states require a higher standard, but Ohio follows the federal minimum. The second component of the home care workforce is the personal care aide workforce. They're often non-certified home care workers who provide care to people living at home. And in Ohio, if they are employed in Medicaid funding settings, the personal care aide workforce is subject to the federal minimum training standard for the home health aides. But if they're in private pay, directly employed by consumers, there's not always that training standard. In Ohio, the direct care workforce numbers about 92,000, and these numbers are based on 2020 data. We've seen over the last 10 years, there's been significant growth in this worker population in the state, and yet median wages remain quite low at a little over $11 an hour. The second component of the direct care workforce we speak about are the certified nursing assistants. So this is over 63,000 workers statewide. And over the last 10 years, there's been a decline in this workforce's numbers, although their median wages are typically higher than you see in home care. Here, they're coming in at just over $14 an hour. This is in line with a lot of trends that we see nationally, where wages in nursing home settings tend to be a little higher than home care, while still overall low wage. And the certified nursing assistant is also a title that requires a federal minimum training standard. Again, it's 75 hours with 16 hours of clinical, and this training is contextualized to the nursing home environment. So to summarize the trends that we've just gone over, there's been a growth in Ohio's home care workforce. At the same time, there's been a decline in the nursing assistant workforce. Some of the factors that contribute to these trends can be incentives for care to take place through different payment programs in home and community-based environments, as well as generational changes in consumers' preferences for where they would like to age or manage their conditions, more often in the home than in a nursing home setting, though these settings continue to be incredibly important for their residents. Now, anyone who's been involved in direct care as a worker, as an employer, or as someone who sought these services for a loved one learns that there are incredible challenges in this space. First and foremost for us are the problems that are facing workers, and these relate to job quality. As we've established, these are low-wage jobs and it's difficult work. It can be difficult for workers to find full-time hours in this field. Sometimes they are asked to cobble together a full-time schedule by working across multiple agencies. And this can make them less likely to access benefits that provide job stability, like healthcare or paid time off. Now, there are incredible training programs across the country, but on the whole, PHI's research finds that where training standards exist for this workforce, they are often outdated when it comes to the skills and competencies needed to provide quality care for today's long-term work client base. Today's long-term care consumers are dealing with more comorbid and chronic conditions than any generation before them. And the standards that exist in this field don't necessarily reflect those skills in every place. And of course, over the last 20 or so months, the risks and stress of COVID-19 has been acute in the long-term care space and affected job quality in this field. This workforce has also experienced, many decades of disrespect and isolation. Some of this is related to cultural values that minimize settings where care takes place for disabilities, illness, or end of life. These aren't spaces that we often see, which can contribute to invisibility for this workforce. And the quality of the direct care job has been also shaped by sexism, racism, and xenophobia over time that have left this workforce out of key labor protections and continue to depress wages and working conditions. All of this together can contribute to feelings of disrespect among this workforce. And the problems facing workers also relate to the problems that face consumers, people seeking to access quality care for themselves or their loved ones. So with workforce shortages and high turnover in this field, that can absolutely affect continuity of care and quality of care for consumers. And unfortunately, when training standards are not robust or well enforced, it can lead to underprepared workers who are not able to provide compassionate, skilled care in the home or in the nursing home or other residential care settings. And because this workforce is traditionally more disconnected from healthcare and social service delivery systems, we believe there's a lot of valuable information about consumer well-being that doesn't reach the care team necessarily, even though it can be direct care workers who spend more time than any other paid caregiver with the consumer. Of course, it is also very challenging for employers and others who operate in this sector. There are often low profit margins and very high operational complexity in this field. That is certainly affected by the recruitment crises that we are seeing from employers across the country, retention challenges, and the cost of turnover. This has been a crisis in this field for many years. It's only gotten worse during the pandemic. And much of these challenges are related to insufficient reimbursement rates, which have an outsized impact from Medicaid, which is responsible for funding around 60% of all home and community-based services in the US. But often these reimbursement rates are set and not updated so that they're insufficient for an agency to provide both a living wage to the workforce or job quality interventions to the workforce and cover administrative costs required for delivering these services. And lastly, again, these challenges have only been magnified during the pandemic. There were often slow or uncoordinated responses to COVID-19 from government programs or through different payers and regulators. In home care in particular, this was one of the last areas that was receiving any kind of PPE or additional financial support for its workforce during this crisis, which is, as we know, affected long-term care consumers very acutely. When we look at Ohio's workforce and its demographic makeup, the direct care workforce, so again, this includes all the titles we've talked about, is disproportionately female. The 90% female statistic is representative of what we see at the national level. But in Ohio, this breaks down to 56% of the workforce being white women and 34% being women of color. It's about the reverse of what we see nationally. Nationally, we see 62% of this workforce as women of color. And this speaks to, how gendered caregiving occupations have been over time. Additionally, when we look at the median hourly wage across these titles and we break it out over these demographic factors, we see that even within the direct care workforce, women in this occupation make less than men. Again, a lot of trends here relate to the larger gender gaps that we see in different occupations across the country. So despite their disproportionate representation, women direct care workers still make less than men in this field. And we see that play out in the poverty rates. Direct care workers in Ohio are more likely to live at or near the federal poverty level than other occupations. And we see that these trends are most heightened among women of color, but also among women overall compared to their male counterparts. So we've established that this can be low-paying, very difficult work with difficult working conditions and poor job stability. I want to get to the fact that this workforce is often poorly understood and understood based on the value the market assigns it, rather than the value of direct care work overall. So there is unfortunately a narrative of direct care work being low skilled or unskilled. And we use some of my own experience. I spent 2 years as a home care worker in my home state of Florida to try to challenge that notion. So when I was a home care worker, one of my clients was a woman named Christine. She was in her late 80s, and she was managing both lung disease and dementia. So it was really critical for me to understand these conditions and how they would affect someone. I needed to understand what the common symptoms were and what would be symptoms that would be concerning. So changes in her rate of breathing, for example, or understanding how her conditions interacted, how her memory loss, would mean that she would forget to reapply the cannula that delivered oxygen through her nasal passage after eating. It's something I had to look out for and make sure we could reapply together. Additionally, I supported Christine with activities of daily living. In her case, that was bathing, toileting, and dressing. It was important for me to know how to deliver that very intimate hands-on support in ways that were acceptable to her, where she felt safe and supported. I also had to ensure her safety in the home. So this meant tracking the cords that were attached to her oxygen machine, making sure they didn't bunch up and create a fall risk. But also, because her immune system was depressed, doing a level of cleaning that meant that her environment stayed hygienic and reduced her risk for infection. One of my other clients, Fred, who was in his early 90s, is a good example of both the physical and emotional strength required of direct care work. Fred was a very independent, animated, and take charge guy. However, he experienced injuries in his legs that meant that he was using a walker or a wheelchair for a number of years. And it was important for me to know the technical skill behind doing mobility transfers, so I could support him, for example, in moving from a wheelchair to the bed, and doing that in a way where I'm communicating clearly with him so he felt safe, but also that I was maintaining my own physical safety, performing that more risky procedure. Now, Fred could also be frustrated with his lack of independence compared to how he was prior to his injury. And sometimes he would take that out on myself or his other home care workers. So I needed to call upon my communication and problem solving skills. Number one, to understand the source of his frustration and try not to take that personally, but also to use communication skills to redirect our conversation and not escalate into a larger argument. So I just give these examples and I put these skills on the screen to really challenge this notion that direct care work is skilled work, as is unskilled work. It is absolutely not unskilled or low skilled. And that perception can be used to continue to keep wages low in this field. And we have to think about how difficult this is. It is not PHI's belief that this should be minimum wage work. When we look at workforce projections for this workforce at the national level, this chart here may not be unfamiliar for folks on this call, right? So we see that the growth in the population that is most likely to need long-term care is outpacing the growth in the working age population, which is the blue line at the bottom of the screen. Those are adults age 18 to 64. So there's tremendous demand, and you see that play out in the job growth numbers that are projected for Ohio between 2018 and 2028. With this workforce having the highest job growth among occupations in the state. Now, job growth, again, is driven by a growth in demand, but when we look at total job openings in this field over the same time period, we see direct care work consistently ranking high, but a significant proportion of the jobs that are expected to be open over this time period are from what we call occupational separation. So not just the growth in demand, but the idea that there are workers currently in this field who leave the field either because they age out, or very commonly they leave this field because of its tremendous job quality challenges. So for the next few slides, I'm going to draw upon words of direct care workers we've interviewed across the country. The sentiment from Farah, who's a home care worker, really gets to the importance of wages and job quality for this workforce and to its overall stability. But I want to emphasize that changing wages can require policy work and advocacy work at the state or federal level, and PHI knows very well that that can take time. And so in the interim, we also want to talk to providers about the other ways that they can add value to the job, even if they're unable to change base wages. So we've developed the 5 pillars of direct care job quality. It's a 29-element framework that speaks to what we believe makes a quality job in the sector. Not every provider is able to implement all of those elements, but we feel that doing so can really go a long way, even with some of these implemented, to add value to this job that better reflects the value that it serves in our communities. So quality training is incredibly important, making sure that training is affordable and available to this workforce or to job seekers in this space, that it covers both the relational and technical skills required for quality care. PHI believes that training should be competency-based so that learners can demonstrate the skills they've learned, not just that they've been presented with those with instructional information, and that there must be hands-on learning for such a hands-on job. Another issue in the field is that the training workers' experience isn't always translatable across different employers or different states. And this is represented in what we hear from this home care worker, Erica. She's had a good experience of training at her employer. Some of the things she does involve skills around wound care, changing catheter bags, and using a Hoya lift. But in her training, she wasn't provided with documentation that she could show other employers in the future so that her skills might be stackable or mobile across different employment settings. The other pillar, of course, is fair compensation. As I said, these wage growth is going to have to happen to change conditions for this workforce. And we want to emphasize that full-time hours can be very critical to this as well as consistent scheduling practices that allow workers to balance their family and work lives. Access to benefit plans through an employer or a union can be critical to workforce stability. And given that this is work that happens in the long-term care space, recognizing that grief support or bereavement leave for someone when their client passes away can be really important to recognizing workers' humanity. Additionally, any mode of base pay increase or financial support goes a long way given the poor working conditions in this field. The importance of pay is represented in this quote from Michelle, she's a CNA, who's really seen what the challenges understaffing can create in a nursing home environment. Our third pillar is quality supervision and support. So we may take it for granted that when we started, our current jobs, we were given a clear job description and representation of what we're responsible for, who our supervisors are, and what we should report to them. That's not always the case in direct care. And we feel that supervision is an area that can really improve job quality for this workforce. It's a key service line for PHI to prepare the people who supervise direct care workers. Access to PPE and other supplies, incredibly important as well. I can't tell you how many workers I've talked to in the last year and a half who've had to purchase their own PPE during the peak of the pandemic. And then peer mentors is another line of service for us. We create programs where direct care workers get to support other workers and helping them stay in the field. So Venetia here is a CNA who works at an agency that's taken supervision, very seriously. You can see the impact on her experience as a worker. She's been a caregiver for a number of years, but it was not until her current employment setting where she actually felt respect from not just her direct supervisors, but also the head of the facility where she's employed. So respect and recognition, very critical for this workforce. It's about making sure that direct care workers aren't just a line item in a budget, but actually reflected in the organizational documentation. Diversity, equity, and inclusion work, again, is critical for this workforce, which is disproportionately experienced marginalization based on gender, race, and nationality. Giving workers consistent feedback, celebrating their milestones, giving them opportunities to influence the organization as well as care planning decisions can be an important source of recognition. And then importantly too, given the level of stigma that's attached to this workforce, training support staff, nurses, even doctors in some settings to value what direct care workers have to say can go a long way in contributing to respect. And you see this represented in Teresita's comment. She's a home care worker in California who was a nurse in her home country of the Philippines, really felt a difference in this occupation when she became a direct care worker in the US. And the last pillar is about real opportunity. And we have to improve the entry-level job in this field, but we also need to make sure that this is seen as a career. Right now, the next rung in the career ladder for most direct care workers, if they're at a home health aide or personal care aide or a nursing assistant level, the next step up is an LPN that can require multiple years of community college, access to resources and academic planning that's not realistic for a lot of people in this field, given resource limitations or family commitments. So actually building in rungs in the career ladder is a key way to build job quality. PHI works directly with employers to develop customized advanced roles within direct care workers' existing scope of practice that allow them to do more. This may be something like a dementia specialist, a care coordinator, a retention support position where someone spends all of their time supporting other direct care workers to help them stay in the field. And we have an example here about the impact these roles can make from Marisol. She was a home care worker for 16 years before being given an opportunity to advance in this field. So altogether, we think about these pillars of job quality working together to transform this occupation. We have documents where we put them all on a single page. And again, there are intense, complex policy issues that we have to address to change working conditions for this workforce, but we also believe there are job quality interventions that are within reach where employers and others can add value to this job to better reflect the value that it serves in our communities. I'm going to go ahead and stop sharing my screen there and take a look at the questions that we have coming in. I'll turn things back over to you, Rebecca.
Thank you. So fascinating. Even though I had a chance to preview the deck, you always hear something new. And I think there's a lot of energy in the chat about really the importance of some of the points that you made. One of the things that has come up really is sort of how do you move to making things happen? And, so we'd love to hear a bit more about how do you take sort of the framework and generate momentum?
So there's multiple levels. I mean, I think one is if we're working directly with an employer, it's doing an assessment of what their particular needs are, what job quality looks like for their workforce, and then figuring out what's reasonable to implement. The 5 pillars are more like what I call the Cheesecake Factory menu of job quality, and it's not always within reach for all of those to be implemented. So we think about where we can prioritize impact. Maybe there's a robust training program, but they're still dealing with retention challenges. So we emphasize a peer mentor program, or developing an advanced role that supports retention. Again, thinking through what's going to be most effective to meet the challenges at hand for that employer. On a larger level, I mean, I'm sure folks in this space understand there's very poor understanding of this workforce, how difficult it is, and what direct care workers actually do in the larger policy community among people who haven't experienced these issues or been in this workforce themselves. So building public education and understanding is really critical to get the conversation started, so we can talk about how policy regulations affect the reimbursement rates and affect job quality in other ways as well.
That's actually a good segue into a follow-up question I had. I don't think you dug too much into it in your presentation, but I did put it in the chat, and that's the Direct Care Worker Story Project, and how important it is, you know, as we're educating the public, to really dig into the reality and what, you know, using these workers' stories to be able to you know, be part of the conversation. There's a lot of talk right now about worker voice and voice of the customer and whatnot. So could you share a little bit about the Direct Care Worker Story Project that you've created?
Yeah, certainly. And thanks for putting that link in the chat, Rebecca. So, you know, I've worked in this field for some time, and I was continually frustrated whenever I saw an article about the direct care workforce, you know, or went to a website associated with long-term care. I'd see the same stock imagery being used again and again. If you Google home care worker or nursing assistant, you're likely to come up with the results that I'm talking about, which typically show, you know, a very aspirational view of what direct care work might be. But you could also use those images for house cleaners or nurses, right? So they're models who are, you know, delivering some kind of assistance to older adults, or much more rarely to people with disabilities. It really, those images are not representative of the demographics of the workforce. They're not representative of the labor involved in direct care work. And they often, in my view, you know, are patronizing to either the workers or the clients. Everyone's smiling, you know, they're great for selling nursing home experiences or retirement communities, but they don't reflect the reality of the workforce. And that contributes to this misunderstanding of who direct care workers are and what challenges they face, but also how important their work is. So we developed the Direct Care Worker Story Project in 2019. And so I work with a network of photographers across the country and employers, as well as my own staff. We go into caregiving environments and we provide professional photography services to capture direct care workers. You've seen some of those photos in my presentation. There's more at the PHI website to try and displace some of the stock imagery with representative images. We haven't been able to be in all care environments during the pandemic. So if you see photos outside with workers in their PPE, we do socially distanced photo shoots. And then we do in-depth interviews to make sure that worker quotes can be a part of the stories that we tell on our website, in our policy advocacy. And we're developing a bench of worker spokespeople who have spoken to Congress, who've spoken to a number of reporters in the last year and a half to really speak to workers' perspectives in this work. We don't have them available for public use just yet. I saw that question come in. It's part of the larger vision of the project. We want to do so in a structure that allows any profit made from the licensing of this images to be redistributed back to the participants and to fuel the ongoing future of the project. So it's part of the plan, but we're not quite there yet.
Thank you. So I welcome questions from the audience, and I certainly could keep talking, but if anyone wants to jump off mute or if there's comments, I'll throw out one more and let you all get ready. So you have talked about working with direct care workers, employers, you've talked about public policy a bit. And, you know, I'm wondering, as you think about where you've had the most impact or strategies you've used that have really brought those groups together, what's floated to the top? What are maybe the top 3 things you've done that has really helped everyone get on the same page as far as commitment to the direct care workforce?
Certainly sharing stories and bringing workers in, doing so understanding that bringing workers to a conversation with lawmakers might not be as easy as it is for other workforces. So understanding the challenges and scheduling that workers might face, and whenever we connect someone to a policymaker or a foundation or a journalist, if possible, we want them to be compensated for their time. We also provide pro bono communications consulting and some other supports to support their success in those environments. So number one is just putting workers in front of people to share their own stories. And one area we've been successful with this is around advanced roles. There's a lot of energy for that in the field. And we've piloted a few roles where we actually integrate an advanced home care role onto the care team. So we have someone, Marisol, who was the last worker pictured in the presentation, was one of what we called a Care Connection senior aide, where she would go into the home and support workers on the job and then bring information from the home care environment onto an interdisciplinary care team. We were able to show the value of that job in reducing preventable emergency room visits, and get a lot of energy around employing direct care workers in positions that pay them more. They are still within the scope of practice of their existing roles, but they show how much work this workforce is doing and how we could better leverage their contributions to care. And then thirdly, I mean, the policy movement at the federal level over the last year, and particularly the last 6 months. So the inclusion of the direct care workforce and home and community-based services in the Build Back Better plan and in this idea of social infrastructure is a huge win, even though the legislation is yet to be passed. The idea that we're thinking about social infrastructure, or that there are conversations about long-term care at the federal level, even just from a public perception or high-level policymaker perception, is a big victory compared for where we were, 10 years ago when I started my work at PHI.
So I think you're looking at another question that's in the chat that really gets to what, if any, legislation is being considered that really looks at accountability in the workplace and increases protections. I guess I would tag on to their what role does labor or worker centers or that whole worker voice piece play?
Yes, it's a huge challenge. I mean, this was something that became very clear during the pandemic, how domestic workers in particular are not protected from, just basic protections around their own safety. And unions can be incredibly important in advocating for this at a state level, at a regional level. I wish there was more momentum around basic safety for this workforce, but unfortunately, it can be really difficult to get those pieces to move. California has proposed some legislation around workplace protections for domestic workers that could provide a model for other states. In other places, it's just about better funding, the systems that account for worker rights, and this can be in both nursing home settings and in home care, and combating, the powerful lobbying efforts of employers who are not worker-centered necessarily, and are not looking to build job quality, but could be exploiting this workforce. So the combination of those efforts. I see a question here about states that are doing a good job addressing this at the policy level. I would say Washington State's been a great example over the last several years in ways to improve pay rates for its workforce, training programs, advanced roles with a wage increase attached to it. There's a lot of interesting work around how this is funded and how workers are compensated going on in Washington State. The 775 SEIU union there has been critical to that, but there's also been a level of state legislation and regulatory change that's supported it.
And so that's interesting. I think that it reminds me that so much depends on the climate of both local areas, state politics as well. But I'm also reminded that there are, I think, employers that are trying to address this issue, trying to use the quality of their jobs as a way to attract talent. And, how do we best support those organizations that are really, or those employers that are really trying to do what they need to do? And then I guess as a final question from my end is, one of the reasons that I wanted to have this discussion was because workforce kept coming up in different conversations. And I didn't see strong connections between what I would consider kind of the traditional workforce ecosystem and the advocacy around the direct care workforce. And so examples of how to best connect those two conversations, I think would be valuable to us in Ohio. It's a lot of individual conversations, I think, at this point.
Yeah, we face that too, right? So the larger workforce community could have a couple models for job quality, but then we talk to long-term care providers who are like, we can't just supply this. There's too many nuances. The role of public funding or just the difficulty of long-term care systems can make implementing that difficult. It's why we developed the 5 pillars model to have very contextualized job quality interventions summarized that recognize the unique job quality issues within long-term care. I think working with employers to understand what their challenges are. So many of these challenges are nuanced based on the payment program, what care system they're in, what the employment model is like. Is it a rural or urban community? What are the particular challenges their workforce is facing? And then getting better public understanding or local lawmaker understanding for what this job is. I mean, it's been shown by different researchers that there are high-level CMS officials who couldn't describe for you what a home care worker does, right? And there's potentially analogs to that at the state level. So it's working with lawmakers who are committed to seeing the impact of this workforce on the community. It's a rare occupation where it impacts a significant proportion of low-wage workers, but also often low-income clients or middle-income clients. It affects 2 members of one's community. So really making that messaging clear to lawmakers who may be in a particular catchment area interested in supporting employers. Foundations in those spaces can be incredibly important too. And then working with employers around their specific recruitment or retention challenges. Again, that's why we pair our technical assistance work in the field with what's needed at the policy level and try to make sure that there's constant communication between those 2 service lines.
So thank you. If you've got further questions for Angelina, you'll have a chance just in a little bit, but I want to bring in our next speaker. So Angelina was able to share a lot of, Ohio data, but also a broader perspective. And I wanted to give you a chance to hear from a local partner about some of the work that they are doing specifically with employers to address challenges faced by the direct care workforce. So Michelle, I think you are on. If you want to turn your camera, well, I could also probably move my page and then see you. But so Michelle Cassidy Collins brings 20 years of leadership experience in higher ed to her role as vice president at ConxusNEO. And at Conexus, Michelle manages research initiatives, coordinates with college and career academies of Akron, spearheads pilot projects, and overall supports the organization's leadership and staff. She is going to talk to us about an investment made by the National Fund for Workforce Solutions in a job design project in the greater Akron area. So Michelle, I'm going to turn it over to you.
Hi, Rebecca. Thank you, Rebecca, for providing this opportunity to briefly speak about the job quality work that we're doing in the healthcare sector in Summit County, and specifically our work with PHI. And it is great to see some of our healthcare partners on the line today. So just briefly, let me share about Conexus. We convened 3 sector partnerships, and it was within our healthcare sector partnership that our employer partners wanted to better understand why individuals weren't entering healthcare. And so early 2020, right before the pandemic, our community partners conducted 4 focus groups with community residents. And it's there that we learned not only why individuals weren't pursuing healthcare, but we also heard from some of the participants who had been former nursing assistants. And we learned why they were leaving the healthcare industry. And so when we learned about the lack of respect that they felt or the lack of support that they received from their managers for their hard work, it became apparent that we really need to be mindful of the National Fund's job quality work. And so specifically to address high levels of turnover, that's where we went initially. And so we looked at the National Fund's job design framework to improve quality jobs. And we connected with some employers who had implemented some interventions which generated successful outcomes. So in turn, we introduced these interventions to our partners. And one of the interventions was job coaches, who are responsible for helping new employees address any challenges that they may be impacting their performance or their attendance. And we want to get those new employees connected to appropriate resources. So we're pleased that more than 10 employers have provided job coaches to their new hires. And that job coach role comes in many forms. So maybe it's a new position that the organization created, and their sole responsibility is that of a job coach, working directly with the new hires, connecting them to resources. Or it may be that those job coach responsibilities were added on to existing responsibilities. And so someone may decrease some of their existing responsibilities and take more of that job coach role. Or it may be our largest healthcare employer in Summit County leveraged a group of employees who are in a leadership academy, and they're across multiple functional areas. And so they're volunteering their time to support new hires and get them acclimated to the organization and connected to employee resources. And so we're really excited that now we're transitioning into that evaluation phase. We want to determine what the outcomes, the impact that adopting this intervention has had on the retention of their new hires. The other, which I think, which is specific to today's, is related to the work that we've done with PHI. So when we heard from those focus groups that those former healthcare employees were not necessarily feeling the respect that they deserved or felt supported, we looked for a supervisor coaching model. And again, we looked across the US, found healthcare employers who had adopted interventions where they had meaningful outcomes. And it's through that research that we got connected to PHI's coaching approach, because we had seen that other organizations had had a positive impact on their retention rates. So we were also immediately drawn to PHI, not only because of the referrals and what we had seen with other employers, but when we went to their website and we saw that they work to ensure quality care for older adults and people with disabilities by creating quality jobs for direct care workers, it just seemed like a natural fit. So it was 3 weeks ago that our first group of 10 managers participated in the supervisor coaching training that was administered by PHI. And the goals of that training really to strengthen the teams by building communication and relational skills. And by doing so, supervisors gain clear communication, learn how to set high expectations, foster the supportive problem solving by employees, with the intention that they're going to reduce disciplinary actions and turnover among frontline workers. And so what we learned from the managers who participated was just how well the coursework incorporated real life healthcare scenarios. So it was relevant to their work, and they felt that they could practice what was taught. And last week, one of the managers was sharing that he participated in the training, and not a day goes by that he's not using something that he learned. And so he wants his employees to feel heard and supported, with the end goal that they feel empowered to solve problems, all while creating a system of accountability. So at Conexus, we secured funding to offset some of the expenses that the employers would normally incur when they would offer such a professional development experience for their managers. So our goal by this June is to have 30 supervisors go through PHI's coaching training. So that's been our experience with job quality work. Rebecca?
Thank you, Michelle. I appreciate that. And it's exciting to see these investments. I did get one question just now relative to the work you're doing with employers. And that was in regard to your comment about the funding and securing funding to offset the costs. Mm-hmm. At what point are employers expected to pay for the training?
So we secured funding to cover up to 30 supervisors. We are contributing half. And then we're asking employers upfront to contribute half as well. And then that funding will be exhausted by June 30th. So at that point, it'll be the responsibility of the employers to fund. But what we feel we've already seen is that there's real value in participating and getting that feedback from the managers. So we hope that just by introducing them to the community and folks seeing the value that it's bringing, that employers will find ways to invest in their frontline managers.
Great, great. Other questions for Michelle or open questions for Angelina? I don't see anything left in the chat. Michelle, do you know of plans across Ohio to sort of scale? I know there's some emerging work in the Cleveland area, but other opportunities across the state to engage? That's one question. And then two, have you thought about how you might take this to a more rural community and what that could look like? Sort of like our strategy is the same, urban and rural. And I would actually direct that to anyone on the call because we have lots of people who know lots about this.
So our intent was when we started to partner with a national fund is that we would be able to scale this work, utilize it to inform not only healthcare and the emerging work coming out of Cuyahoga County, but we're hopeful that it will go across sectors, right? So if we can continue to create better and better jobs for our residents, at the end of the day, yes, I previously supported our healthcare sector partnership. So that's very important. And it's so important to Northeast Ohio. But at the end of the day, all of these industries, manufacturing, others are really important to our local economy and they provide good jobs. So that's our intention. Gotcha. Your other question regarding rural versus urban, that's a great question. And I don't have an answer for it because we're a metropolitan area and we haven't thought about rural. I'm sorry.
No, that's okay. I think it's, it's just something I'm grappling with and have to keep asking about. So, well, I think that sums up the questions. Are there other questions or comments? We'll have to have you back in a few months and ask you, Michelle, if those employers are still thinking about their training at that point. But anyone else on the phone or on the session? Otherwise, we can give you a few minutes back and wrap up here. So I think we're good. I don't see any hands raised. Thank you for being here. Well, so here's a question of apprenticeship. Has there been exploration of apprenticeships? That's interesting. I actually don't know the answer to that.
There's been a little work at the federal level that I'm aware of, particularly around CNA, but also some home health aide apprenticeships. They've been limited in their implementation. There's an organization called HCAP that's been really involved in shaping those opportunities. But there's a lot of connections that have to be made. You get federal funding, but then also having employer relationships and a sense of the workforce community where you are to want to funnel people into this occupation through those platforms. So I'd say there's been some, but it hasn't been widespread.
Thank you.
Yeah. Well, and I'm excited in Ohio, may not necessarily be relevant, but how Cincinnati recently launched an MA apprenticeship. And so I think as we continue to see the launch of some apprenticeships, I'm hoping that it will spread throughout the state.
Great. Well, again, thank you for joining us today. If you are interested in this topic in more detail, I think there are additional conversations that should be had. Please reach out to me, and I'd love to see some stronger connections with some of the workforce leadership across the state. Our webinars are usually on Thursdays, the third Thursday of every month at 1 o'clock. You can see previous webinars at ohioworkforcecoalition.org. And I look forward to having you all continue to engage as we try to tackle these workforce questions. Thank you very much. And thanks to our speakers. And we will be talking to you all soon.